My name is Michael Singer. Today we're going to talk about the evolving world of AMD diagnosis and treatment. Here are my financial disclosures. So we're going to give you an overview of macular degeneration. We're going to talk about the two types, dry and wet. We're going to talk about the history of current therapy. We're going to talk about where we are now. We're going to talk about what's coming on the horizon. So dry macular degeneration is by far the most common type of macular degeneration, and it's the type that we currently have the least amount of treatment options. Essentially, what we really have is ARADS vitamins, which is the age-related eye disease study, and it was ARADS 1 and ARADS 2, and the original ARADS 1 had 15 milligrams of beta-carotene, 500 milligrams of vitamin C, 400 IUs of vitamin E, zinc, and copper. And the new ARADS formula, they eliminated the beta-carotene and replaced it with lutein and zeaxanthine. And essentially, the ARAD study showed that beta-carotene was associated with lung cancer and stroke and smokers, so they decided to change the formulation. And by boosting with lutein and zeaxanthine, it got an extra 20% reduction in AMD progression in those with the lowest dietary intake. It's interesting to note that omega-3 fatty acids showed no benefit. And essentially, this is the study. It shows that your risk goes down about 20% if you take a combination of lutein zeaxanthine with DHA and EPA. On the horizon, however, we have new therapies that potentially may slow down the actual disease of dry macular degeneration, but in particular, geographic atrophy. The best way I like to explain this to my patients is if you think of dry AMD as carpet. If you walk on the carpet, what happens? Initially, it can wear away. If it wears away, this is called macular degeneration. If it wears away to the floorboards, it's called geographic atrophy. And if it happens to hit a pipe, this is called wet macular degeneration. We're going to start with dry macular degeneration. We're going to talk about drugs to see that hopefully will decrease the progression of geographic atrophy. And there are two basic companies that are currently farther along in phase 3 trials. One is Apellis, and they have the Derby and Oaks trial. And the other is Iveric, and they have the Gather 1 and Gather 2 trial. Both of these therapies are based on a complement cascade, and the complement cascade is something used to fight inflammation. And there are two portions of the complement cascade that they fight. There are 3 different arms of it: the lectin, alternative, and classical pathway, and they all converge on this thing called C3 convertase. Pegcetacoplan, made by Apellis, blocks C3A, and evacepagenol, or Zimura, blocks C5. So essentially, you can see very clearly that these different pathways do different things. And you can see that where you are in the pathway, depending how you block, you can either block C3A, which is the pro-inflammatory things preventing inflammation, opsonization, or essentially you can block C5A. And this is a nice schematic to show you what's going on with the different drugs and how they block. So Oaks and Derby were phase 3 design studies using pegcetacoplan by Apellis, looking at patients with dry AMD. They were randomized to monthly, every other monthly, and then sham monthly and every other month. And the primary endpoint was at 12 months, and the end of study was at 24 months. And I'm going to show you the 18 months data, which essentially was recently released, that showed a value in both the Derby and Oaks study. The Oaks had a much better reduction in progression of 22 and 16% versus the Derby, which was 13 and 12. There were 4 cases of infectious endophthalmitis. There was new onset wet AMD of 9.5% in the monthly and 6.2 in every other month. And there was 0.23% of intraocular inflammation, but no occlusive vasculitis or retinitis. This is the 24 months that recently was released, and you can see that between 18 and 24 months, the Derby study got much better, with a reduction of 19% at 24 months versus 16% in every other month, and the Oaks were 22 and 18, which essentially show that over time, this medicine seems to have an effect, getting greater as time goes on. And this is really illustrated with this slide, where you can look at the difference between the difference from sham, and it's month 0 to 6, it is about 12 to 13% in terms of whether it's monthly or every other month. But if you look at month 18 to 24, these differences are much bigger. They actually double or more than over time. So again, it shows the longer you take the medicine, the better off you are than natural history. Another way of looking at this is where the lesions are located. In the Derby and Oaks trials, lesions were included whether they involved the center vision, the fovea, or they were outside the fovea. And you could see that both in foveal lesions and extrafoveal lesions at the Derby and Oaks trial between months 18 and 24, you saw a lot of improvement in terms of reduction in the lesion size. What was a little disappointing, however, in the 24-month data was that no clinically meaningful or statistically significant differences were seen in the key functional endpoints like vision, visual acuity, low luminance visual acuity, reading speed, or microperimetry. And obviously, this is very disappointing because as we talk to our patients, that's how they see the world. They don't really appreciate lesion growth. As I mentioned before, we talk about the fact that these drugs, although they slow down dry macular degeneration, they do actually cause an increase in wet macular degeneration. And at 24 months, it was 12% in the monthly, 6.7% in the every other month, and 3.1% in sham. Infectious endophthalmitis was 2 cases confirmed and 2 cases suspected with a rate of 0.34 at 24 months. And intraocular inflammation at 24 months was 28 cases overall, or 0.24% per injection. To the point I mentioned earlier, there were no effects of occlusive retin, vasculitis, retinitis, or occlusion. So in summary, overall, it was well tolerated with patient geographic atrophy with a safety profile consistent with trials of intravitreal therapies. Most of the intraocular inflammation were mild. You had 12%, 6%, and 3.1% of development of wet AMD in monthly, every month versus sham. There's an extension study called a GALE that will go out for 5 years to give you a better understanding. And it is actually undergoing review by the FDA November 26th and of 2022. So we talked about this. This is just another way of explaining it's the first, has the potential to be the first treatment for dry macular degeneration, especially geographic atrophy. The other company is Iveric, or the GATHER2 study. And actually, there were 2 studies. There was GATHER1 and GATHER2. GATHER2 was recently released. And GATHER2 showed a Zimura, or a vinacinate head call versus sham. And the primary endpoint, just like in the Apellis study, was the mean growth in geographic atrophy from baseline to 12 months. What's interesting to note, there was not an every other arm in this thing. It was just every monthly. And then at year 2, that people will be transferred to every other month. The inclusion criteria was non-center involving GA, so that's different from the Apellis, and had to be within this 1,500 microns from the center of the fovea. In addition, patients in the pegcetacoplan trial could have wet macular degeneration in the fellow eye. This was an exclusion in patients in the GATHER2 trial. And when we talk about 1,500 microns, this shows you what 1,500 microns is, that essentially it can involve the fovea, like the first 2 pictures on the left that are included, and it can't be greater than 1,500 microns outside the center part of the fovea. Both the patient disposition was, very good in terms of most patients made it all the way through. Most patients got their injections over 90%. Well balanced. The lesions were well balanced as well. This is the primary endpoint, that in the GATHER2 trial, there was a 14.3 reduction in the growth rate versus sham. And this was based on something called the slope analysis. And then the observed analysis was even better with 17.3% reduction versus sham. In terms of treatment adverse events, they were well balanced between the 2 arms. Of note, there was, choroidal neovascularization occurred in 6.7% in patients treated with Zimura versus 4.1%. IOP was increased. What's important to understand was that these numbers were very small, and there were no cases of intraocular inflammation or endophthalmitis or ischemic optic neuropathy, which differs it from pegcetacoplan. In terms of CNV, or choroidal neovascularization, 6.7 versus 4.1%, we talked about that. And This shows you in Gather 1 and Gather 2, both were able to decrease the growth of geographic atrophy at 12 months. We're going to switch gears and go to wet macular degeneration, because in wet macular degeneration, there are a number of therapies out there, and they continue to increase over time. Essentially, we're looking at patients initially could be treated with ranibizumab, aflibercept, or bevacizumab, or brolucizumab, or faricimab. All these medicines have gone through phase 3 clinical trials with the exception of bevacizumab or Avastin. So these are the different molecules, and they work a little bit differently. You can see their names and their format, and essentially some are fusion proteins, some are something called Fab fragments, some are single chain antibodies. So they're all a little bit different. They all have a little bit different concentration, and they all act on VEGF just slightly differently in terms of their concentration and molar amount. The Lucentis trial was first, or ranibizumab was first approved, and it was approved by a phase 3 clinical trial called Marina and Anchor. Marina was a patient with minimally classic or occult neovascularization, where it means you can't put a circle around it so easily. And Anchor was versus something called photodynamic therapy. So the Marina study was against sham, but PDT or photodynamic therapy was used in the Anchor trial. And you could see that there was a huge improvement in treatment versus control, with over 20 letters in both trials. Aflibercept or Eylea had the View 1 and View 2 trials, and you could see very well. In addition, both medicines did very well. The control at this point, because ranibizumab was approved, was ranibizumab, and you can see there was non-inferiority at 52 weeks in both the View 1 and View 2 trials. The CAT study was a multi-center study looking at ranibizumab versus bevacizumab. And essentially, it was not a pivotal trial. It was something that was sponsored by the NEI, the National Eye Institute. And patients had 4 treatment arms: ranibizumab monthly, bevacizumab monthly, ranibizumab as needed, and bevacizumab as needed. And ranibizumab increased visual acuity more than bevacizumab, but there wasn't a statistically significant difference between the two. However, monthly injections overall, regardless of your drug, did better than as-needed injections, and switching from monthly to as-needed ended up with a decrease in vision. And this is shown here with the graph, that the top graphs are monthly. So you see at the 104-week, the blue is ranibizumab, does better than bevacizumab, and it does better on the as-needed, but monthly is superior, regardless of your drug, to as-needed. And that's something we've learned throughout all our wet macular degeneration trials. The more you shoot, the better you get. The 5-year extension that showed essentially people over time, what happened is all the vision they gained, they lost over 5 years, because when they lost over 5 years, they didn't get as many injections. When you're not in a clinical trial, you don't get as many injections, and it didn't make a difference what arm you were in. Everybody lost vision. They actually lost lower than baseline. So we talk about injection frequency. Anchor and Marina were pivotal. View 1 and View 2 were pivotal. CAT was not pivotal, and again, monthly dosing gave better results than as-needed treatment. Brolucizumab is a newer medicine that was recently approved in the last few years. It's had something called the Hawk and Harrier trial. It was compared to aflibercept given on label with loading doses and then every other month. The Hawk and Harrier trials had something called disease activity assessment, and depending on how active your disease was, you ended up getting put in either an 8-week or 12-week arm, and over time you would be followed for that arm, and any time that you at special treatment points that you've had a disease activity, you could drop down. The primary endpoint was at 48 weeks, and then the study end was at 96 weeks, and you could see very clearly whether or not it was 3 milligrams or 6 milligrams. It was comparable to aflibercept that was given on label, and there were 2 different trials, but they showed pretty much the same thing. In terms of drying the retina, both drugs did a better job through both 3 and 6 milligram, both concentrations, than aflibercept in drying the retina, especially in the match phase in the green on the left. The problem was after the drug was approved, patients started getting intraocular inflammation. And not only was it basic intraocular inflammation, they also got retinal vasculitis and retinal vascular occlusion. And overall, what happened was 4.6% of patients started to develop intraocular inflammation. 3.3% had intraocular inflammation and retinal vasculitis, and 2.1% had intraocular inflammation, retinal vascular occlusion, and retinal vasculitis. and patients less than that, you ended up having a certain amount of patients actually losing greater than 15 letters. And you can see the pie chart on the right that less than 1% lost 15 letters, but this was a significant unexpected surprise seen in our patients. And a lot of analysis was done, but they never figured out exactly why people were at risk for developing it. The newest medicine that has been approved is faricimab. Faricimab is a combination of an anti-VEGF and anti-Ang2 medication. It has, in the beginning, we showed it as two arms. One head is anti-VEGF, the other is anti-Ang2. Anti-Ang2 basically causes vessel stabilization. It is an anti-inflammatory type molecule, and the hope is that it would do a better job than anti-VEGF alone. The Tenaya and Lucerne studies basically compared treating people at different disease activity endpoints. The faricimab had 4 loading doses, while aflibercept had 3, and then was loaded every 8 weeks according to label. Then patients in the faricimab arm could have a disease activity assessment at week 20 and week 24, and depending on a combination of changes of BCVA improvement and CST criteria, they would put it into either a 12 or a 16-week arm. And at the primary endpoint was averaged between 40, 44, and 48. And then the PTI, or the patient treatment interval, was ongoing till the end of the study. And the patients were well balanced between different arms. And you could see very clearly that the vision was pretty much stable in all the arms. And essentially what they did was they averaged the faricimab arms, both the PTI and the regular arms, and the aflibercept. But the interesting thing is that you had much fewer injections versus week 108. Aflibercept had 15 injections. Faricimab, overall, if you went up to 16 weeks, you essentially had 108 injections. And then in the PTI arm, even after week 60, you only had 3 injections versus 6 injections. And you could see very clearly, look at week 12 and week 16, which were the different groups that people could fall into in terms of patients could either be every 8 weeks, every 12 weeks, and every 16 weeks. You could see that 60% of people in Tenaya and 66% of people in Lucerne were able to go 16 weeks. And overall, 74% of people in the Tenaya and 81.2% of people in the Lucerne trials could go longer than 3 months, which essentially was the first time medicine of this nature had been shown to go this long. Obviously, we worry about intraocular inflammation after I told you what just happened with brolucizumab. The good news is the amount of people with intraocular inflammation was relatively low in the different arms, although it was a little higher than sham. We're looking at small numbers. Endophthalmitis in the faricimab was 0, and there was only 1 case in the aflibercept arm. So in conclusion, this faricimab was able to target 2 distinct pathways that promote vascular stability, leading to more durable therapy with maintenance of long-term vision gains, with 63% of patients could go to Q16 weeks and 80% greater than Q12 weeks. And you could still have comparable visual acuity improvements and CST reductions over all treatment arms through week 112, and it was well tolerated with no case of retinal vasculitis or occlusive retinitis. And there's a long-term study called the Avenel X will generate 4-year data. Recently, high-dose aflibercept was released, and the Pulsar study was done, and this was released at Subspecialty Day, and patients were given higher dose than regular Eylea or aflibercept. Aflibercept was 0.2 milligrams. This is 0.8, or it's 8 milligrams. Sorry, it's 2 milligrams versus 8 milligrams, and they essentially compared patients with 2 milligrams every 8 weeks. It's a standard dose, and then they use high dose every 12 weeks and 16 weeks. And the primary endpoint was week 48 of non-inferiority. You can see the dosing schedule. Important to understand, patients initially were given 1 shot, then they had 2 visits where they weren't seen. And essentially at week 12, what happened was they were evaluated. The 2Q8 kept going every 8 weeks, and then there was the same disease activity assessment, and people fell into either different buckets based on whether or not they would had disease activity. And then patients could have modification based on whether they had a 5-letter loss of BCVA and worsening and 25 micron increase in CRT from week 12. So they looked at patients at week 12 and then they put them in different groups. And you could see what happens, is that all three groups did well. That regardless whether you were given unlabeled 2 milligram every 8 weeks or you were given 12 or 16 weeks, patients did well. And you can see that 63% of people with the 8 milligram group were dry versus 52% of people were dry at the 16-week interval with the regular standard currently approved 2 milligram group. But what's really interesting to know, the proportion of patients at year 1 who maintained their vision at Q12 and Q16 weeks was 79% and 77% respectively. And if you go greater than Q12 weeks overall, 83% of patients had dosing intervals longer than 12 weeks. In terms of central retinal thickness, the drugs were pretty equivalent. In terms of adverse events, the adverse events essentially were balanced between the different arms. Intraocular inflammation was low and balanced between the different arms. And again, no endophthalmitis or occlusive retinal vasculitis or occlusion. These are more safety events. There wasn't a systemic difference between the different drugs. And again, the Pulsar study did show that they were able to get, essentially over 83% of people going Q12 weeks or longer. So there's another system that's being used that was approved this year called the Port Delivery System, or Susvimo. And this is like a pump. And it's basically a ranibizumab pump you put in the eye. It's a surgically implanted thing, and it basically gives medicine over time. It's placed in the operating room. And what it does, based on diffusion or Fick's law, the medicine is filled up and diffuses over time. And it goes from the higher concentration in the implant to lower concentration in the vitreous. And you can see that essentially typical shots give you bolus up and down, while patients with the PDS have much more fixed medicine over time. Again, you can think of it like an insulin pump. This is how it's put in. It actually is something goes through the pars plana. You actually make a cut with a super sharp blade. And then what happens over time is you cauterize the choroid because you don't want to have any bleeding. You make sure the wound is 3.5 millimeters in length. You increase it with a super sharp blade, and then you put in the actual implant, and you can see that right here. And that's with the hole in the middle is where you're going to use for what's called refills. You put it in place, and then they sew it up. They sew up the conjunctiva to make sure it stays in place. And this is what it looks like 1 month after the PDS implants. And the study that actually looked at was the Archway study, and the Archway compared standard ranibizumab given monthly versus the PDS over time, and weeks 36 and 40 were the primary endpoint. And they wanted to have non-inferiority in terms of the PDS, in terms of vision and OCT. And you can see here's the schematic. Patients were able to get refills, or actually rescue therapy, not refills, rescue therapy before the 6-month time point, and then patients got refilled at the 6-month time point and went from there. Criteria for rescue is listed below. You had to have 100 microns or loss of 15 letters or an increase of 150 microns from the lowest measurement. Also a 10-letter loss. People were well balanced across the arms. You could see that it really was pretty equivalent to monthly injections in terms of vision and OCT. Refills, 98% of people didn't need a refill in the first 6 months. And you can see that at the different intervals over time, over 94% of patients could go refill free. Or instead of refills, I meant rescue free. So you didn't need extra shots. So for over 94% of people, once you filled it up, it stayed filled for 6 months. Ocular adverse events were relatively low. There was conjunctival blebs, and there was a certain amount of endophthalmitis, which was considered a bit of a problem overall, but essentially we're talking about 2% or less. So in summary, it really did very well. It was able to have over 94% of people needing only 6-month injections, actually not even injections, but redosing of the medicine over time, and had a good safety profile. The vision was comparable to monthly shots as well as the OCT drying. And it was approved earlier this year. So let's talk about the future. So we showed you medicines that last longer. Now we're going to talk about gene therapy. We want something that essentially lasts potentially even longer than the port delivery system or the high-dose Eylea faricimab. So there are two basic companies. One is REGENXBIO, the other is Adverum. RGX-314 uses something called an AAV8 vector to make a Lucentis-like protein or a ranibizumab-like protein, while Adverum uses an AAV7-8 promoter to use like an aflibercept type protein. Essentially, the OPTIC study was using Adverum. Adverum was actually used using intravitreal injections. They were just basic shots. These were patients who were hard to treat and had a long history of shots, were given a aflibercept and then at day one given the gene therapy treatment, and they were followed over time. And they could have rescue criteria. And you could see there were 4 cohorts of patients, and they had a lot of injections. You can see the number of injections prior to being in the trial was anywhere from 7.1 to 9. So these were what I call frequent flyers with relatively decent vision. And you can see at each of the cohorts, the number of people who need rescue was very small. Actually, in cohort 1, it was nobody. In cohort 4, it was 1. Cohort 2 and 3 were lower doses of the actual medication. They did have higher doses were associated with a little bit more inflammation. We'll go about that. But the interesting thing was the mean annual injection rate, and the high dose went from 10 shots to 0.1 shots versus low dose, it went from 10 to 1.5. So a 99% and 85% reduction respectively. In terms of adverse events, most of them were mild and controlled with steroids. And by the end of the trial were resolved in all groups. They were, like I said, 78% mild, 22% moderate. And you can see over time, there's a decreasing trend of aqueous and vitreous cells as you increase the use of steroids. So it essentially reduced the burden in wet AMD. There is a study that is being started right now called the LUNA study, which is phase 2 trial, looking at this medication in wet AMD. There's a little bit of a larger steroid prophylaxis in which patients are getting both oral steroids or Ozurdex or topical steroids. RGX-314 had their phase 1/2A fully enrolled. They had 5 cohorts over time. This is a subretinal injection. That means you had to take patients to the operating room and stick the medicine under their retina. They had different patient and different criteria. Retreatment criteria is really investigator discretion, so it wasn't spelled out. There was different cohorts in terms of the concentration, and a large number of patients had prior therapy. You can see the number of injections is large, 33 injections, and the 9.6 injections prior to entry. Overall, the safety was pretty well controlled. There was a little bit of retinal pigmentary changes. There was no intraocular inflammation otherwise to really speak of that got resolved. That was really more postoperative inflammation. Remember, these are vitrectomized patients. Overall, it was well tolerated. However, it is a bigger surgery. When we look at the visual acuity over time, patients in the higher cohorts had better visual acuity. In the lower cohorts, it probably wasn't strong enough. And when you go to cohorts 3 and 3 to 5, you can see that patients do much better over time for visual acuity in terms of the number of injections they need. The higher the cohort, the less injections that are necessary. There is a good job in controlling the swelling in the different cohorts as well. The higher concentration led to better control of edema and less rescue injections. There currently is a long-term follow-up on these patients that are going to be seen over time to make sure that the medicine still works and what is the incidence of rescue injections. And you can say this is the beginning of the long-term follow-up at 3 years of cohort 3, and they still keep 12-letter improvement. They have a number of different programs going on for both actually wet macular degeneration and diabetic retinopathy. I'm going to talk about one of the trials that is going on where they go from subretinal to suprachoroidal. Though subretinal surgery has very good results and has much less inflammation that is not related to the operation, it's not very useful in terms of being able to be done in the office. So suprachoroidal therapy or the AVA trial is going on. And this is a video, I think, of what happens for suprachoroidal. This is using a heat map. This is my friend Mark Barakat, and what he's doing is he's actually injecting the suprachoroidal gene therapy in the patient's eye. And you'll see that as he starts to inject, it diffuses back. This uses the clear side needle, and the concept is there's a difference in intraocular pressure from the lens to the optic nerve. So the medicine that's put in at the suprachoroidal space, which is not a real space, it's kind of like blowing up a balloon, and it gets squeegeed down to the back of the eye, because the disease we're fighting right here is macular edema due to macular degeneration. And you can see right now, he's starting to inject the medication. And very soon you'll see as the medicine starts to change, you're going to see it, a blob, and it's going to move over time. And this is actually measuring where it is in the suprachoroidal space. Currently, this needle is being used on label for steroids for patients with macular edema in something called Zypir by Bausch & Lomb. And a lot of these injections have been performed. So the AVA trial looked at patients who essentially were previously treated similar to the original Regenex Bio treatment, bio subretinal patients. And they had the RGX, they had an anti-VEGF injection at day one, then they had the medication suprachoroidal, and they have different concentrations over time, where they went from 2.5 to 10 to 11 to 5.0 to 10 to 11th in dose escalation. And the primary endpoint is going to be at 1 year. You can see patients are having lots of shots before. The number of shots since their diagnosis is average of 13.4. About 22 years, these people are frequent flyers. They had 6.5 injections in the last year. And then if you the annualized injection last year was about 9. So again, high flyers. You can see cohort 1 that patients with ranibizumab had with 7 injections, they had about 6.8 versus 2.8 letters lost. So again, it shows that you don't need a whole lot of injections, but just like the subretinal, probably this is not the strongest cohort that would actually be used going forward. And you can see this is CRT, that ranibizumab does a better job, but it still holds its own. So and then actually the results for diabetic retinopathy are even more impressive. The suprachoroidal RGX-314 is well tolerated, and the 6-month data shows a meaningful reduction of injections by 75% or 76%. And 4 patients had mild inflammation, which resolved within days. So currently the AVA study has actually been expanded to cohorts 4 and 5 with a much higher dose level, and we hope to see future results at future meetings. So in conclusion, multiple pathways are being evaluated to help retinal treatment options. We're creating better VEGF molecules, more sustained deliveries, we're inhibiting a new mechanism of action, and we're using gene therapy. The future is really bright for our patients. So in summary, our patients are getting even better treatments over time for both dry and wet macular degeneration. For dry macular degeneration, we may very soon have a treatment that will slow down the progression of geographic atrophy, and after that, maybe even a second one. And for wet macular degeneration, the concept of monthly therapy is being replaced by longer-acting medicines that can last as long as 4 or even 6 months currently, and may actually, with gene therapy, may get down to either 1 injection or no injections per year. So again, it's a very exciting time to be involved in retina. I thank you so much for your attention.
All right, everybody. I wanted to thank Dr. Singer for that amazing presentation, going with the different treatments for AMD from start to finish. It was just a clinic on how to actually go from here to there and everywhere. And we also want to give a special thanks to Dr. Singer because he's actually in Taiwan right now doing some lecturing over there. So we really appreciate his dedication. So you all want to know the raffle code, right? The raffle code of the day for this one is MGD, meibomian gland dysfunction, MGD.